Nope, it didn't. Now it will be recorded. It'll be available here on our Facebook page, as well as on the OHP website and our YouTube page. So you can return to it and view it anytime. As Dr. Marcinek shares, please use the comments to ask any questions or to share some of the things that are happening in your practices or changes that you've made. The comments will be available with a recording on Facebook. So any additional best practices that you want to share, please do so. We encourage it. Use the space to connect tonight. With that, I will turn it over to Dr. Marcinek.
Hi, everyone. I'm Julie Marcinek. I'm trained in Grant Medical Center in Columbus, Ohio, and other than a stint in DC for a year, have been practicing here ever since. So this kind of evolved out of conversations that we've all been having around COVID and the stresses we've all been having around trying to manage this and change things and learn telehealth really quickly. But I wanted to talk about just some silver linings that I have seen through all of this. And while I've also shared some of the anxieties and everything that we've all experienced, COVID has actually been a bit of an energizing time for me as I've watched my health system kind of pull together and create systems to try and address this epidemic from a population perspective. And so I'm going to share some of those with you. I should say that I'm kind of presenting on behalf of myself and representing myself, and I'm not representing OhioHealth specifically in this capacity, although I'm going to be talking about a lot of the interventions that we've put in place. So the silver lining that I talk about with COVID has really been that it has exposed a lot of the holes in our healthcare system that we've been talking about for a long time. That this, over the past several years or several decades, we've had this inpatient heavy, push everything to the hospital model that is expensive and is sick care, not well care. And while value-based payment certainly has plenty of its own headaches and frustrations, the benefit of value-based payment has been watching hospital systems really start to pay attention to the ambulatory space in a way that I didn't see in a fee-for-service model. What COVID did was light a fire under that because suddenly hospital systems had to look at doing the exact opposite of what we have previously been doing, which is minimize unnecessary hospitalizations and surgeries and minimize exposures to the healthcare system. And so that was really the driving force behind a lot of the interventions and changes that I'm going to talk about. When the hospital says minimize unnecessary hospitalizations, what many of us who work in primary care and in population health here is strengthen primary care, strengthen outpatient services. So that's what we tried to do. So we started by looking at social determinants of health and trying to use those as much as possible to drive some of these interventions. So how do we do that? At OhioHealth, we have a really great team of case managers and social workers, and they just got on the phone, started calling our patients that have already been identified as high-risk social determinants of health patients, knowing that one, if these patients were to get COVID, they are some of our highest risk for bad outcomes, and also that they may have limited resources to make it through quarantine and to really hunker down at home. So they called, they texted, they emailed, and reached out to these patients. Hey, how are you feeling? Are you having any health issues? Do you have your medicines? Do you have enough supplies at home, like toilet paper and all of those things that are going to help you safely stay home through this whole thing? And also try to identify those things that, if unaddressed, could lead to that unnecessary hospitalization or preventable hospitalization. They made about 25,000 calls to patients and interacted and addressed issues as they came back. I think they said that about a third of the patients that they reached out to that needed some sort of additional intervention that they were able to address. And all patients, either on those phone calls or in blast emails, received a phone number for case management to, hey, if something comes up, we're here, call us, we'll help. We had a couple of other social determinants of health interventions already in the works that came in handy. First off, OhioHealth's collaboration with Aunt Bertha, the online social resources website, just kind of happened to go live in the middle of the COVID epidemic. So trying to give both patients and providers a regional specific resource to try to access ambulatory services like how to address housing instability, food instability, addiction, medicine, etc. And we already do have an existing ambulatory consult of social work in our system so that outpatient providers can access the case manager or social worker that's assigned to their practice. So next up is the telehealth. We are finding new ways to use technology to reach patients. As we talked about here, we have all become Zoom experts in the past 8 weeks and Facebook Live, and that is no difference in our telehealth and our interactions with patients. I think most of us have gotten crash courses in telehealth and telehealth billing, and thank you to the state of Ohio for opening up reimbursement and CMS for opening up reimbursement for telehealth services. We very much hope that that stays in place. But also we tried to get creative with what else can we use telehealth for? What does it look like to do diabetic education via telehealth? How can we use MyChart, which is our patient interface, to help monitor patients? And we piloted this with our COVID patients. If you were a COVID positive patient, you received a questionnaire via MyChart every day. Let me rephrase, a COVID positive patient that was well enough to quarantine and be treated at home. You received this questionnaire twice a day asking, how are you feeling? Are you having a fever? Are you having any respiratory symptoms? What is your clinical condition, so that if it is worsening, how can we intervene sooner rather than later to address your needs and keep you out of the hospital? This feature was originally built for other disease-specific things like COPD and diabetes. And so, again, we got a bit of a crash course in how does this work and how are we going to hopefully continue to use this moving forward for chronic disease management. Our case managers were also able to use telehealth to fulfill our per member per month requirements to keep that payment model going. We then were able to use some kind of new existing resources in new ways. We have about a year and a half ago, we opened 2 new units called the short stay units. This was a bit of a brainchild from our hospitalist group to try to challenge what can be done and treated in an outpatient setting. And so these are outpatient units that can be an OBS unit if I need it to be, that really has access to everything that an ER has, IV fluids, IV antibiotics, stat testing, things like that, that if treated in 8 hours or less, I can bill you as an outpatient and get you out the door. And so over the past year, we've really had a lot of success in these units in being able to challenge what can be done as an outpatient and try to get patients good care for a lot cheaper than sitting in an observation unit in the hospital. Certainly as COVID hit and we were trying to keep those unnecessary transfers and unnecessary observation stays down, the short stay units got pretty nimble and pretty flexible with how we could try to help out with that. I think we can all imagine the patient that we have in the office. We have a high suspicion that they have a DVT, but they don't really need to go to the hospital. You just need a Doppler now. The outpatient, the short stay unit would be a great option to get that stat testing now, rather than having to send them to the ER. So the short stay units existed prior to this and to COVID, and we kind of reimagined them and utilized them in different ways. Advanced home services was sort of again, a brainchild that we had been working on and pushing for a while that we didn't get the green light for until COVID hit. Advanced home services is kind of built off of the Johns Hopkins Hospital at Home model, if anybody's familiar with that. This is home health on steroids. This is trying to do hospital level or observation level care in the patient's home using existing home health infrastructure. So a patient would get signed up for advanced home services, and our home health would triage the patient. Yes, this is appropriate for advanced home services versus you can do traditional home health. One of the main distinctions being that advanced home services you can do without an established PCP. In that setting, home health would come out within 24 hours for advanced home services, and you would have a daily virtual visit from an outpatient provider. We had a great team of OhioHealth outpatient primary care physicians who kind of rose to the challenge, and we kind of had a rotation of, I believe, 14 PCPs who would take shifts doing these virtual visits, reaching out to patients. And so far, again, has been quite successful. They would have daily virtual visits, daily home health visits. That home health aide would get medications, draw labs. We have a lot of virtual monitoring equipment that was just constantly transmitting heart rate and O2 sat and all of that. Generally, patients have stayed in the system for 5 to 7 days, give or take. And after that point, they either get a warm handoff back to their PCP or connected to a PCP. And if they still need help, they can be transitioned to traditional home health services. And then to help coordinate all of this is the virtual health team. And this was my baby, so we're going to talk about that. So I've just talked about a lot of different possible ways to access care. And I think one of the challenges right now in transitions of care is that it looks a little bit too much like the red side of this page, that there's just a lot of individual pieces moving individually, trying to get their patients to the best situation they can figure out. But there's not much of a coordinated approach, and it relies on us to even know, like, what are all of the resources available. The virtual triage team was something that we created that is staffed by case management that providers can call, whether it's from outpatient, urgent care, ER, whatever, saying, hey, my patient needs a higher level of care. I don't know that they necessarily need to be in the hospital, but how can I help them do that? And to try to have a slightly more coordinated approach to getting patients where they need to be without the ER necessarily being the default for that. So this was structured as, again, a case manager initially takes the call, or social worker. Also, a hospital medicine service physician is staffing at all times so that if there are clinical questions, if you need provider-to-provider communication for whatever reason, we're there and supporting. And we just help advise on, hey, these are your options to get the patient the care that you need. The ER or a direct admission may be the best option, but do you know that we have the short stay units, and here's what they're capable of? Would that help? Can we help connect you with home health now? Can we help connect you with advanced home services? Can we help facilitate a same day or next day primary care specialist visit? How can I help you get stat radiology testing or cardiac imaging that, again, you don't necessarily need to go to the ER for that Doppler or whatever you need. I had a friend of mine that used it because she was concerned about an ectopic pregnancy for a patient in her office, and ended up having to send the patient to the ER just to get an ultrasound to rule out an ectopic, something that could have been done as an outpatient. And then triaged from there. So those are kind of just a quick run through of all of the interventions that we built or strengthened or changed to try to keep up this goal of keeping these unnecessary hospitalizations down and supporting the ambulatory space to have the resources to do that. As with anything, there are limitations and struggles and growing pains. I'd say our number one limitation, which is not on here, is, I guess, maybe changing workflows. It's all new. We literally did probably what would have been 3 years worth of population health development in traditional Ohio health world in about 6 to 8 weeks. So it has just going to take time for things to kind of catch up and people to get educated that things even exist and work out bugs. So changing workflows has definitely been a challenge. I helped develop the Silly Triage team and have tried using it from the hospital to prevent, hey, I don't think this patient needs to come into the hospital, and have often still not been successful at preventing that admission. So it's a growing pain. But one thing that we've really, again, I think those of us who work in population health have been saying for a long time, but was both troubling and oddly satisfying to be proven right on. Many of our patients that are high risk with their social determinants of health don't have access to the technologies that our hospital system so often wants to depend on to fill those access holes. My geriatric patients, they either don't have a smartphone, they don't know how to use it, and just culturally, they're not as comfortable interacting in that way as, say, a 30-something millennial. If you are in a low socioeconomic situation, you don't have an iPad. And so really exposing that technology can be beneficial, certainly, but it cannot be the panacea for all access issues. That we really need to be able to meet our patients where they're at to be able to provide them the care that they need. Another limitation certainly has been patient and physician education and buy-in. I kind of spoke on that already. But part of that is just, again, knowing that these resources exist, but really changing the way that we think about addressing acute issues, and how do we script things for patients that, you need to go to the hospital may not be the correct answer, and how do we rework our own individual workflows in our offices to access some of these lower acuity resources. The ever-present question of what do you do with patients without primary care physicians? This is a battle that we've been fighting in the hospital for a long time, and I don't have great solutions at this point. It's probably been one of our biggest barriers in trying to prevent some of these readmissions. The triage team has done a phenomenal job trying to connect people with PCPs, and our outpatient community has really stepped up in trying to be able to accept, even through a virtual visit, patients more quickly. But primary care systems are overwhelmed as is, and so trying to bridge those gaps is a challenge. And finally, and arguably most importantly, is payment. Again, I'm so thankful that some of the payment changes and that have happened during the COVID epidemic with regard to telehealth, those need to be sustained and expanded. I will be the first to admit that our advanced home services program, we're just not getting paid for, other than the virtual visit that the doc does every day. The home health component, we do not meet most insurance companies' requirements in terms of documentation, having a PCP, all of those things. And so this is one that frankly, we've just been eating the cost on, other than, again, that telehealth virtual visit. And so having some payment reform that allows us to sustain this sort of work financially will be crucial. And so to wrap it up, these are the things that my very large, well-established, well-staffed healthcare system was able to do in a very short period of time. I know that for people that are in smaller environments, where they're less resourced environments, this is perhaps a bit beyond what is capable, and certainly in that timeline. But I really want to put in the plug for the Everyone Project. I'll admit I heard about the Everyone Project repeatedly and never really looked into it. Once I actually went onto the website for the AAFP's Everyone Project, it is really quite impressive. And the tools that are available, I would just highly recommend for anybody who's wanting to do some social determinants of health and population health changes within their individual practice or within a smaller group of practices. Their toolkits have, everything from slide presentations and worksheets and everything to help your individual practice kind of work through, hey, what's our process going to be for addressing some of these things? So on the other end of the spectrum, here are resources to help you with policy and advocacy interventions to try to create some of these changes, payment reform policies that help support improved social determinants of health and trying to keep patients healthy rather than just treating them when they're sick. So I would really encourage you to check that out and see if any of it makes sense for your practice. So that is my fun, exciting developments that we've done over the past 8 weeks or so within OhioHealth. I would not wish a COVID epidemic on anyone, but as they say, never waste a tragedy. And I think that we have done a good job of doing just that, of finding the silver linings and finding the opportunities that exist here to hopefully put some systems in place that can exist long after the epidemic to address social determinants, narrow health equity gaps, and just strengthen outpatient and ambulatory care. So this is my email address. Please feel free to email me questions, comments, concerns, anything. I've also included Dr. Chris Esber. He is my partner in crime and boss in all of this. He's the director for transitions of care for our hospitalist group, as well as the medical director for the short stay units, and has worked 10 times as much as I have on all of the above listed interventions. So happy to take any questions. And again, I don't claim to be an expert on any of it, but we'll hash it out and see what solutions we can find.
Thank you, Dr. Marcinek, so much for sharing kind of what you guys have been going through. We did have one comment and question from our Facebook comments, and it's kind of going into the last statements you were making. Great interventions. What things have you learned that could be implemented in small practices with very limited resources? Could you elaborate on maybe some things you've learned in that regard?
So I think again, I'll go back to my shameless plug of the Everyone Project, because I think it actually does a better job than I ever could of kind of walking through what that process could look like. Because my experience is on the large aggregate hospital system. I would say that, and this is an overly simplistic answer, but just being engaged with it is kind of the first step. That I think that we all feel pretty overwhelmed by social determinants of health. And this is something that we in the primary care community have known for a long time, that our patients with, higher risk have worse outcomes. And it's not that we just haven't been addressing it, we just don't kind of know where to start or have the resources to do it. And so one of the things that I like about the Everywhere project is there's this worksheet that you go through that you just kind of identify what is our process right now for addressing this, and what are small changes, what resources do exist in my community. Stop focusing on what we don't have. I grew up in a rural area. Both of my parents are primary care physicians in rural West Virginia. They owned their own practice for years, sold to a for-profit health system several years ago. So I get it. And I'm the one who rants and raves about, people in cities telling rural areas what they should be doing. It's like, well, that doesn't even exist here. So rather than focusing on what you don't have, focus on what you do, because I guarantee that your community has so many resources to address various issues, whether it's, hey, housing stability, not our strong point. We don't really have those resources right now, but we have an awesome food pantry. What can we do to try to help connect patients, to screen patients for food insecurity, and then connect them with this awesome food pantry? Or, hey, I know that church in their basement has an AA meeting every Wednesday. And so what can we do to try to help screen our patients for substance abuse issues and get them connected to that meeting? And then I think also on top of that, I would say, think of your community think of your health community as a community. I think that when you're in a small town, a lot of the times things are not as coordinated, that people tend to be operating in silos, that there's this family practice over here and this cardiology group over here, and then the hospital is over here. How can we start thinking about each community, even if you're in a different hospital system or business model? How can you guys work together to achieve those goals? I understand these are not easy or simple things, and I'm not going to pretend to have a panacea to those problems. That's me more going rogue and talking about growing up in a small town as the kid of a primary care doc than anything that I personally know from my professional life.
You can give it one more minute or so. If anybody has any questions or comments on tonight's topic, feel free to put that in our Facebook comments. I will end with just one last one at least, and give a couple more minutes for our audience. Do you see any health equity gaps being impacted as a byproduct of the work that you're doing? It seems like a lot of what you're doing is kind of a start to some of that. Kind of what's next? What do you see with some of this work?
So yes, I definitely see those health equity gaps being addressed. And I like how that's phrased, and that it's kind of a byproduct of this work. I would love to say that health equity and social determinants of health were the driving force behind this. What really happened here was the hospitals said, oh my goodness, this model of filter everything to the hospital is the exact opposite of what we need. We need to completely undo that. And so what I hear as a family physician hospitalist, when the hospital says reduce readmissions, reduce unnecessary admissions, what I hear is strengthen primary care, address social determinants of health. Because we know from research that that is what achieves that goal. We know that what I do in the hospital only impacts the patient for about 7 days after discharge. So where you prevent those hospitalizations, it happens long before you ever showed up in my hospital, or really before you ever got sick. And it continues long after you leave my hospital. And so I think that the systems that we have started to put in place are going to help us, one, use data and use social determinants of health data to drive these interventions. and give our case managers, our primary care physicians, our urgent care docs, the tools that they need to address health equity issues from a structural standpoint. And I'm hopeful that the data that we pull out of this experience really affirms that, yes, when you do address health equity issues and when you address social determinants of health, you do see better health outcomes.
Absolutely. Thank you so much again for sharing. I don't think we have any additional questions, so we will start to wrap this up and keep this short and sweet. I'm going to share one last slide with you all, just with a couple additional resources. There we go. The first link here is just resharing what Dr. Marcinek has shared for the AFP Everyone Project. Please do check out that resource. It's very valuable, a lot of helpful tips and tricks and worksheets, as she mentioned. And if you've done any of changes like Dr. Marcinek has shared, you can also get credit for that for your American Board of Family Medicine certification performance improvement credit. So this bit.ly here is an actual step-by-step instruction video that will show you how you can walk through that application process and claim credit for the work that you're currently doing. It's about a 10-minute process. If you have any questions, please feel free to reach out to me and I'm happy to assist you. We also have a couple other web pages here for resources. Our COVID-19 webpage, we keep that updated. Joy Among Chaos webpage, check that out. There's free CME webinars there and different resources and articles. And then of course our bite-sized learning webpage, we'll keep updating that as we have more and more sessions, which brings me to our next week's session, June 7th at 8 p.m. right back here. We will have Dr. Heathen Patel, an OSU graduating resident. He's going to share his perspectives on just being a graduating resident during these times. And then keep an eye out for any future sessions that we have coming up. And if you have your own story that you would like to share, please email me and we'd be happy to have you jump on here with us and share. So let's see. I think that is all for us. Enjoy the rest of your Sunday evening and thank you so much.
No problem. Thank you.
Okay, I think we're off of live. Ooh, I had no idea what I was rambling on there, but.
Great job.
Yay, yes, you did so good.
Hey.
There we go.
Yes. Good work.
Yep, cloud recording.